like to welcome you to another AIHI seminar, and my name's Enrico Coira, if you haven't met me before. We have a special, in the good sense, seminar today. We thought when we were planning the seminars that we always have lots of speakers from overseas or externally, but we rarely get to hear of the brilliant work that we do here. What we're going to do today is have the opportunity to listen to Professor Johanna Westbrook's work. Jo, as you know, is the director of the Centre for Systems, Health and Safety. I always get that wrong. Chaser. And I've known Jo really for your whole informatics career, I would say. Is that correct? We're old. I'm older. And Jo has really for that whole time been interested in work practice, workflow, the way people interact work, and the way that shapes the use of technology for good or for bad. And it's fantastic to have seen that work be increasingly recognised internationally and locally. And I have to say, if you don't know, Jo is now on the board for the new Australian Digital Health Agency, and I've got to say it's fantastic that we've got some real academic rigour shaping policy at that level. That's fantastic. So normally you'd have to buy a ticket to go to an international conference, but today, for free, Professor Jo Westbrook.
Thank you very much, and of course it's really nice to be here among friends and colleagues. So today I'm just going to give a bit of an overview of some of our areas of research around clinical work patterns, safety and health information technology. So many of you will be familiar with the team. This is the team from the Centre for Health Systems and Safety Research, and we have 6 broad streams of research in terms of different content areas. But what also underpins all these streams is an interest in developing new methods for looking at patient safety and looking at the impact of health information technology. So today I'm going to be touching on some of the studies that cut across a couple of these streams of research. In order to answer one of our core questions, research questions, which is really how does health information technology impact safety and how does it support clinical teams to be innovative in their work, we really have to start understanding what do we mean by clinical work and how do we actually measure it. And so what I'm going to do today is talk a little bit about how we've thought about how you might measure patterns of work and communication, specifically focus on a few studies we've done with junior doctors because there hasn't been previously a lot of work in this area. And then some ideas about how we're trying to think about linking work patterns to clinical outcomes. So a good starting point before you embark on any large-scale evaluation or assessment, you have to think about what's your model of the healthcare system. And so on the right-hand side, a traditional way that you might see a healthcare organisation is that it's like a well-oiled machine. Sometimes people talk about that. And really it's you can set out a series of policies and procedures from on high, and everyone in the organisation will follow those policies and procedures. It's very rigid. You've got a series of control. It's a bit like, you know, when Jeffrey tells everyone in the institute to do something, everyone runs around and actually does it. But we know from experience that's not true. And really, healthcare is much more like a complex adaptive system. It's like a living organism. We have independent agents all going around with their own agendas as well as working together. And so therefore they adapt to the environment and they continuously evolve. And so when you introduce large-scale interventions like a clinical information systems, they may use it in unexpected ways. And I think it's a bit like this. So I think this is a really good example of a complex adaptive system. So obviously all these drivers have, you know, learnt to drive, hopefully have a licence. But really they're acting as independent agents, but every now and then you see that they work together to get through the traffic. And most of the time it works really effectively. And I think this is a bit like healthcare work. It's actually quite mesmerising. You can sort of watching it. So it's very, very funny, actually. Okay. So what are some different approaches we've gone about recognising that we're dealing with a complex adaptive system, that work is formed in teams, how might we actually go about trying to describe and measure it? So I want to briefly talk about two methods that we've used. One, many of you will be familiar about some early work we did using social network analyses. So here, this is the social network analysis of a large emergency department in Sydney. So every dot on that figure represents an individual staff member, so there are about 103 in that department. The blue represent nurses, the red represent doctors, and the green represent administrative staff, and there are occasional yellow ones which are allied health staff. And this is us, we ask them, how often do you go to the various people in your department to help solve a work-related problem? So it describes the extent to which they are communicating together. And you can see for this department, it's quite a dense network, and with social network analysis, you come up with a series of metrics to be able to describe and quantify those relationships. And then you can change the types of questions that you ask to see whether different people are working on different issues together. So here is the same group of people, but we specifically ask them, who do you go to seek medication advice? And not surprisingly, you see that the green people, with the admin people, are very much on the periphery, and the nurses and the doctors are much more centralised. But you'll also notice that it's still very profession-based, so still very tribal, even though we talk about multidisciplinary care. The circled doctors are the senior doctors, and in emergency, senior doctors are much more integrated into networks than we found in other areas. So we were then interested in saying, well, can we actually link these networks to any information about outcomes? Because there's a lot written about the fact that if we can improve communication among teams, we know that that's important to reducing errors. So in this study, what we did was we looked at 2 hospital wards, and we asked them about the extent to which they seek medication advice from their colleagues on that ward. And the first thing you notice is that the ward on the left, there's a lot more activity, a lot more exchange of information going on than the ward on the right. The pharmacist is central to each of the wards. They're sitting right in the middle of the network. These are the senior doctors. And so you can see on the ward on the right, there are 3 senior doctors. No one goes to them for advice, and they provide advice to no one. And then on the other ward, they're still pretty much on the periphery, but slightly more connected. And then what we did was we did an independent review of all the patients' medication charts on those wards to actually quantify the prescribing error rates. And that's what we found. So we were totally blind to the networks at that stage. So on the ward on the right, they had 9 prescribing errors per 100 patient days, and the ward on the right had 19.4. And then we also, as part of the network survey, we asked clinicians on the ward what they thought about communicating with each other about medication tasks. 84% of staff agreed that if doctors and nurses talked more frequently, there'd be fewer errors. On this ward, 54% agreed that that was the case. And so I thought, even though this is only a comparison of 2 wards in one hospital, it starts to give us some sense that communication is probably incredibly important to contributing to potential error rates. And I think it also goes to this idea of complex adaptive systems, this idea that you can have 2 wards in the same hospital, governed by the same policies and procedures, the same quality managers will be operating in those hospitals, and yet obviously the cultures of those wards are very different, and it's also reflected in their outcomes. And so for us, one of the questions is, how do we help to design health information technology which is going to support better communication, which produces better outcomes? So another approach to looking at communication and work patterns is doing direct observation. And trying to look at work patterns is something that's been the interest of many different researchers. And this is one group of researchers who tried to look at successful people who seemed to spend a lot of their time writing about how they spent their days. And they come up with these lovely diagrams. They're nearly all about men. I think the women were too busy to be writing about it. And also they'd need lots of concentric circles for all the multitasking. But anyway, so this is an example of how they've represented that data. And here we've got Sigmund Freud, who, and they seem to have very regimented patterns. And so I think one of the questions asked is, what are successful patterns of work in healthcare? What do they look like? And how can then we design information technology which supports those safer and more efficient work patterns? And really, in order to do that, we need to understand what's currently going on. What are the patterns that currently exist in different work organisations? And we really need to start pushing the methodology in this area, because there are some clear gaps. So we started on this journey by actually trying to answer the question, okay, well, how do doctors and nurses distribute their time in hospitals? And we wanted to quantify it. There's lots of qualitative work where they've done interviews to ask clinicians about this, but we wanted to actually quantify it. So we started on a long journey developing some sophisticated time and motion techniques, and then we developed some data collection software which we call Wombat. And in essence what it is software where we have our researchers shadowing doctors and nurses on hospital wards, and they collect information about what tasks the clinician is undertaking, who are they doing that task with, how are they doing it, so what are they actually using, what artefacts are they using, where are they physically located, how frequently are they interrupted, and also we classify the nature of the interruption, and how frequently are they multitasking, which is actually, we use parallel multitasking or dual multitasking, which is doing two things at the same time. Most frequently, it's doing things like writing a medication order while also answering a question from a colleague. And the advantage here is, one, we're getting some multi-dimensional information about the tasks that are underway, but also everything is automatically time-stamped, so it allows us to actually quantify and looking at patterns of work. So this is a short video which will give you a little bit of sense of how we used it in practice. Now this is actually based on our Wombat version 1, which was a PDA version. And here we have one of our researchers holding a PDA. She's observing the nurse, the blonde nurse behind the desk.
She's having to wait for someone to come on the phone. Is that still
We need to get it home.
Okay, so now we're going to indirect care. She's been, I was looking for one, but she's just been interrupted by the nurse unit manager.
Angelique?
And I can translate the nurse. So she's going to be giving direct care to the patient. So we go straight to patient, direct care. And she'll be making a bed. Scanning papers, that's not documentation, that is really just gathering equipment as well. So she's just been interrupted in what she's done by the patient. So we're going to direct care of the patient, interrupt, and enter.
Okay, I'll walk you over.
Okay, so now she's going to assist the patient.
So that just gives you a sense of what it's like in the field, and obviously the researcher wouldn't be speaking to the camera normally. And so what we've done is we've done a number of studies at different organisations, and the very basic level is actually just to answer questions such as, well, what proportion of time do doctors and nurses spend with other patients, with nurses, doctors, relatives, etc.? Because it is quite amazing if you go into most public hospitals and say, well, what proportion of your clinical staff time do they spend with patients? They don't really know. So it's interesting to get some baseline data about those types of things. We've also can look at the fact that obviously task time distribution will change over the course of a shift. So this is a graph from a study at 2 ICUs in Sydney, looking at the way in which task time changes over the course of a day. Now, one of the other questions that for us came up fairly early was the idea that once you introduce interventions such as electronic medication management systems, which require doctors and nurses and pharmacists to significantly change a sort of series of tasks, what impact will it have on them? And early qualitative work, where we interviewed lots of staff at hospitals, they were very concerned, pardon me, that they would spend all their time with computers. It's going to take me forever to do a medication task. etc. They also were saying, well, currently I spend all this time following up, trying to find medication charts. At least now I won't have to do that. So they were identifying considerable concerns about the introduction of the system. At the same time, they had the system vendors coming and saying, this is going to be fantastic for your life, you won't know yourselves, you're going to have less time in administrative tasks, more time to spend with, in direct patient care. But when we looked internationally, there's very little quantitative data to demonstrate whether there were shifts or not. And so that's why we undertook a controlled before and after study to actually try to measure whether those patterns of work changed before and after the introduction of an electronic medication management system. And so in summary, we were focused on 3 broad areas of work: the time spent in medication tasks, in direct care with patients, and in professional communication, because we know that's so central to sort of safe care and of patients. And what we found was that the doctors on the intervention wards had no significant changes in the proportions of times they spent on those work tasks, which we were also quite surprised about. We did find some differences. So we found that doctors on the wards that had the electronic medication management system spent more time with other doctors and significantly more time with patients. And we found that they spent less time with nurses. And there are a number of reasons why this might be the case. So the fact that clinicians were now doing some of the prescribing on computers at the bedside would mean that they were closer proximity to patients. We also found in the early days that doctors started to use the system together. So in the past they independently prescribed, but when the system was introduced and they had a room where the computers were all set up, they would often work on the system in pairs, which was, one of those unexpected findings. And for nurses, the fact that they spent less time with doctors may be due to the fact that the location of this work shifted. So clinicians moved to doctors' room where the computers were available, whereas in the past they tended to do prescribing around the central nurse's workstation. So there was more opportunity for sort of serendipitous conversations. Now, of course, the question is, well, is this good or bad for quality? And at the same time, we did a very detailed medication error study. And that we found on the intervention wards that there was a significant reduction in serious prescribing errors. So it went from around 25 per 100 admissions to 14. So still lots of scope for improvement, but there was some clear evidence that the system was having a positive impact on error rates and relative to the control wards where we saw no significant reduction. Okay, so what we've found is that other people have been asking us for Wombat. And so we've been able to share it. I thought I'd also give you a fact about a wombat that you may not realise. Wombats are very ergonomically designed, and you will see that is the wombat's baby. And the wombats actually have their pouches focused backwards so that when they're burrowing, they don't get dirt on their baby wombats. So I thought that's rather lovely. Anyway, so I thought you should go away with at least one fact about a wombat. So we started Wombat in Australia, and we've now been sharing Wombat with teams around the world. And the nice thing about this is that we're starting to generate data sets in different healthcare systems, in different environments, and looking at the opportunities that might give us to start saying, are there similarities and differences and whether they're important. So this year, for example, we collaborated with some researchers in the US. The American Medical Association were very interested in looking at the impact of electronic health records on clinicians in their private practice. So they wanted to use Wombat, and we sent Marilla over to the US where she trained 10 observers to go around and watch 57 US physicians in their family practice and to actually report, how they were spending their time. And it was very interesting working in a totally different healthcare system and some of the tasks that they had that they wanted to collect information about, which obviously we don't have around the sort of financing of healthcare. We've also been working with colleagues in the UK. So in the NHS, they're introducing electronic medication management systems like we are here. And one of the professional groups that are most impacted are hospital pharmacists, and yet we have very little data on really what impact it has on their work. So, we both had similar questions about how would this system introduction impact their pharmacists. And so we said, why don't we do a study on Wombat to measure this. So here you can see the initial results from this study. So here we have the broad tasks, some of the broad tasks that pharmacists undertake. The first column of data represents the proportion of time at baseline. So in the UK hospital, pharmacists spent 27% of their time doing medication reviews. For Australian pharmacists, they spent around 12.5% of their time doing medication reviews. And so you can go down history taking. In the UK, it's 19.4%. In Australian hospitals, they're spending around 7.6% of their time. And we spent a lot of time using the same definitions so that we could do some comparisons. Now, the second column represents what happened in the post period after the introduction of the system. And so it's interesting, first of all, that there were differences at baseline between the work of the two countries. But then we were interested in saying, well, are the changes experienced similar? And that was interesting too. So we found that pharmacists in both countries, the proportion of time they spent on medication reviews increased, which is one of the areas that really there's an expectation that it should go the opposite way. History taking also increased, which is also an area where you would think these systems that provide you with better information, you would see a reduction, but we saw an increase. Both countries, pharmacists spent less time in supplying medications. That's probably because they're too busy doing reviews and history taking. And then we looked at time spent with different people in the organisation. And what is very clear, both at baseline and in the post-period, Australian pharmacists talk to other health professionals a much higher proportion of the time than the UK pharmacists. And it's been very interesting starting the discussion about why this might be. It's a really significant sort of cultural difference. And you can see for the UK pharmacists, actually the proportion of time they spent on work-related discussions decreased in the post-period, and they had fewer interruptions. So we're really just exploring what we can make from these types of comparisons, how valuable they are, and it's quite early days, but it's sort of it's an interesting exercise. One of the other things we've realised is that obviously patterns of work, even for a particular professional group, will change at different shifts, different times of the day. And we're very interested in looking at the work of junior doctors. There's been a lot of research looking at the hours that junior doctors work and trying to restrict the number of hours they work for safer care, but there's been much less work done on what do they actually do when they are at work. And so we were interested in examining that. So we did 3 different Wombat studies, and different members of the team were involved in this. We did a study during the day, where we followed them for 150 hours, during the night for 96 hours, and then on the weekend. I think is Lauren here? Yes, Lauren spent her times on the weekend with 16 junior doctors for 160 hours. And we're interested in saying how do their patterns of work differ at these different times and what might they mean. So this is a real summary table of what we found. So first of all, we found, if we look at social, and social is having a break, having some food, and you can see that on the weekend, junior doctors are spending around 9% of their time, which is less than 1 hour in a 10-hour shift, having a break, compared to during the day and the night where they have much more time. They're interrupted at an incredibly high rate. So 6.6 times an hour they're interrupted, which is around the rate that senior consultants in emergency departments are interrupted, compared to 2.2 and 1.3 at different times. They also, on the weekend, spend the greatest proportion of their time in direct clinical care, and yet they receive the lowest amount of supervision during that care. So I think you start to build a picture of what the implications for safety might be. And one of the points that Lauren made in her study was, the extent to which we know that there's a weekend effect, and our colleagues in CAI have done some, really important work in that area. around, the types of patients and what's happening to them. But also it may be related to what's going on in terms of the work patterns of the clinicians at the same time on the weekend, and how that may be contributing to that effect. The other question is, well, what are the implications therefore for health information technology design to be able to support this one professional group? And junior doctors are the professional group that probably use these clinical information systems the most in hospitals. How do we design them to deal with these big shifts in their patterns of work? And so there are things about, the extent to which these systems are supportive in terms of allowing people to keep track of multiple tasks. So it may not be such an issue during the day, but if you're suddenly thrown into being interrupted, 6 or 7 times an hour, how are you going to keep track of all the clinical tasks you have, and how can information technology assist that? How can we help with reducing cognitive load by managing all those concurrent tasks and being interrupted while you're trying to do them? But also recognising that we're probably dealing with very fatigued users. So this has implications for the interface design. An interface design that will work when you've had a good night's sleep and you're bright and bushy, versus when you're really sleep deprived, you're being interrupted and you can't remember all your tasks. You have to think about, do we actually test for human factors issues with fatigued users as much as we do with those who are well rested? And how do these systems potentially adapt to users' needs at different times? The other thing I want to talk about is the fact that we know that junior doctors may use technology in ways that are both expected and unexpected, and that you have to take into account the context in which they are working. And so there's some really nice work that was led by Melissa, who's not here at the moment. So what she did was she actually said, let's do some observations of doctors on ward rounds and look at them interfacing with the electronic medication management system, and look at what they do when alerts come up on the screen. So what she found was that following these teams for about 60 hours, nearly half of all the orders put into the system generated an alert. And this was actually in a quite early system that only had a few alerts turned on. 17% of those alerts were red, and she had a very generous definition of red. So if they cast their eyes over it quickly, that was considered red. And not one order was changed in response to any of the alerts that were generated. So you say, well, why is that? Anybody who'd been on a ward round, who makes the decisions about the medications, and who is entering the orders? So you have the junior doctors entering the orders on the system, and you have the senior clinician running the ward round. And so who is getting the alerts is not the decision maker. And we didn't see once a junior doctor who's using the system, alert the rest of the team to, I've just got an alert, should we check that? So really one of the conclusions we made in this study was, well, potentially you could say we should turn the alerts off during ward rounds, because all we're doing is training doctors to ignore them. So we then thought, well, when might they be useful? So we followed junior doctors at night to see whether they changed their behaviour with the way they responded to alerts. So we followed them for 65 hours. 78% of all the alerts were red. And 5% of the orders they placed were changed in response to those alerts. So it suggests that certainly in different environments, they may be quite useful. But I think it really is a clear message about you have to understand the context in which people are using these interventions, as well as just focusing on the intervention. Right, I wanted to focus on gorillas now. So many of you may be familiar with this research group. They're a team of psychologists who have a particular interest in selective attention and have a particular interest in gorillas. And this is a study they did called The Invisible Gorilla Strikes Again. So they did a study where they took 24 radiologists and they asked them to review 200 CT scans of 5 patients who were typical lung cancer, for typical lung cancer screening. And so they showed them scans such as this. There are 200 of them. And you might see that here they placed a gorilla in 5 of those scans. There it is. And what they were interested to see is how many of the radiologists actually noticed the gorilla was there. So, do you want to take any punts? How many of the 24 radiologists do you think detected the gorillas? Oh, you see, group of researchers, they're all sceptics. Okay, well, 20 of the 24 radiologists missed the gorilla. 4 of them found it. They then did the same experiment where they had 25 non-trained reviewers and they all missed the gorilla. Now, the message from this was not that these radiologists were poor at their jobs, and they identified all the relevant clinical aspects in the images, but that really this idea of selective attention, if you only go into a situation looking for a certain, scope of things, that will be all that you will see. And so one of the core messages from this work is that it's very important that you are willing to look for more than one thing if you're going to set yourself up for success. And I think that's a really good message to go into when you're doing this type of research with the impact of clinical information systems, that you have to be looking for the expected and the unexpected. Okay, so moving away from gorillas and back to the emergency department. Now, emergency departments are really a nice window into complex adaptive systems and the way people work. And many of you will know how busy emergency departments are. And we're really interested in understanding how does work get delivered in emergency departments and how do we measure that. So we've had Scott Walter, who's been working on this as part of his PhD, which is now through. And he wanted to extend some of the methods that we've been using to look at not just when clinicians get interrupted, but trying to look at what response do they have to those interruptions. So they undertook, so Scott with some colleagues, Magda was spent some time doing the observations here as well. They looked at 36 ED physicians in one of our large ED departments. And what they did was they recorded how physicians responded to interruptive external prompts. And the options a clinician has is that they can respond to that prompt by task switching, which is sort of, you stop what you're doing and attend to the new task. You can try to take it on and do it together, so answer the question while continuing to do what you're doing. You can just acknowledge it, thanks, got that information. You can defer it, I'll do that in 5 minutes, just leave me be. Or you can deflect it, give it to Dr. Jones. And so we're interested to see how they use these different strategies. What we found was, as many people have found, that the rate of interruptions or external prompts in emergency departments are very high, and the prompt rate increased with seniority. So the senior clinicians were receiving external prompts around 10.6 times per hour. But once they were in transit, you can see the rate went up substantially. It's a dangerous task for senior physicians. They were interrupted 37.6 times per hour, but least likely at the bedside. So you're starting to get some pictures that people make decisions about when to interrupt, when potentially it is appropriate or safe to do so. The most frequent response was to task switch. So in 68% of the time they stopped what they were doing and addressed the interruption or the prompt that was coming in. They acknowledged 21%, and multitasking is used to a relatively small amount, 8%, and that's partly because people are physically can only do a couple of things at the same time. But what was interesting in looking at the results overall and during the observational study is that in this setting, this prompt response process, particularly between junior and senior doctors, was working very successfully. That the senior doctors were not very concerned about the high rate of interruptions because it's part of their role to be overseeing what all the junior doctors are doing. They're checking in all the time, checking, I'm dealing with this patient, answering short questions, responding to bed management issues from nurses, and that was really a fundamental way to the way the department was working. And generally people thought that worked quite successfully. So, because one of the issues here is that interruptions tend to be seen always in a negative sense, but they may just be a very, useful strategy to use in many situations. But one of the questions we start to ask is, well, when do these management strategies of task switching and multitasking perhaps are effective, and when might they be more risky? So what happens when the context changes and the patient load of the department suddenly increases? Will this prompt response, highly interruptive environment still be successful? And also, what about the individual characteristics of the clinicians in that environment? Does it make a difference? So what happens with this sort of environment when you're really, really tired? Can you as just as successfully deal with these strategies? And also working memory capacity. So when you look at the psychology experiments, working memory capacity shows that some people are much better at being able to cope with an interruption than other people. So the higher your working memory capacity, the better you are at being able to deal with interruptions. So we've been very interesting to see whether we could start exploring some of these issues. And so this is a protocol that we put out to not only look at these different behaviours, but also to see whether we can link these to a clinical outcome. So what we've been doing with this ED study is to not only capture all their interruptions, but also look at when they were making a medication order and looking at whether the error rates increased if they were multitasking or interrupted. Also, we're collecting information about their level of sleep and whether that made a difference to whether they made an error. We tested them all for their working memory capacity, and everyone in the centre had to do it first too, so that was a bit stressful. And we also got the majority of them to wear heart monitors as they were being observed. So we've got lots of data, and we're just in the process of looking at it, and there's some interesting results to come out. But part of the reason why we went down this path is that we're trying to cross disciplines from taking some of the psychological research, which is very much done in an experimental setting where they can control everything and they can interrupt them and they force them to do multitasking, and say, what have they learnt there, and can we then look at some of those phenomena in the real world applied settings? So we all know about multitasking and driving. So we know that if you look at your phone, use your mobile phone while you're driving, you'll increase your risk of injury or death by 31%. It's a good message to take away from this talk. So is it as risky in a clinical environment to be multitasking? Well, you might think, well, it's not the same to be, looking up a pathology result while also answering a question. That's not the same as driving a car and using my mobile phone. But simulations have also shown that if you're just listening to a passenger while you're driving the car, that your performance deteriorates, that you're more likely to deviate from the road and things. So don't talk to your passengers. So it shows you that even quite minimal multitasking may have an issue for safety. Now, another thing that we've been very interested in that we did early work on is looking at what happens with particular safety critical processes like giving medications to patients and interruptions. And so one of the studies we did a number of years ago is to actually look at observing nurses as they administer medications, looking at their rate of interruptions and seeing if it was associated with error rates. So it was a direct observational study, 2 of our major teaching hospitals. We shadowed them. We observed over 4,000 drug administrations. We looked at what drug the patient received. Then we went back and looked at the record to see did the patient get what drug was ordered in the right dose and strength to identify errors. And then we looked at were the errors associated with interruption rates. And we found a dose-response relationship. So the more interruptions the nurses received, the more errors they made, and the more severe those errors were. So that gave us, at least for certain safety critical processes, interruptions may not be a good thing. And people's approaches to that is to say, all right, well, we need some strategies, therefore, to reduce these unnecessary interruptions. And so we've seen many hospitals start to introduce these types of interventions where you wear a vest while you're doing medication administrations. You try to warn patients not to ask questions. This is what we'd all like to wear. But how effective are they in the long run? And so, Magda did a systematic review a year or so ago, looked at all these interventional studies and really found that they generally weren't great design, but they really didn't present a lot of evidence to suggest that these interventions, one, reduce interruptions, and virtually none of them really looked at whether subsequently it reduced error rates. And I think the other thing that we really need to think about with these types of interventions is that they are very invasive. It sounds simple, I will just put a vest on when you're giving medications out, but it actually involves a lot of other types of interventions. You have to get staff to decide, all right, well, if you're not going to be able to be interrupted, who's going to deal with those interruptions? We have to educate people not to interrupt, etc. So we more recently we thought, well, let's do a cluster randomised controlled trial to see whether these interventions actually are effective by using a robust study design. So we did this study in Adelaide, and we were particularly looking at reducing non-medication related interruptions, not just all interruptions. And, we found that, yes, if you introduce the vests, there was a reduction in the number of non-medication related interruptions. But using our previous study, which showed the relationship between interruptions and errors, we're sort of estimating that given that reduction in interruptions from 50 to 34 per 100 administrations, you probably maybe get a 2% reduction in errors. And so, yes, the intervention is highly effective at achieving a reduction in interruptions, but I think what we're questioning is you need to think about the investment in the intervention, the disruption. We asked nurses after the end of this trial, would you like to continue with this intervention? And 48% said yes. Actually, more people on the control ward said yes, they'd like to do it than on the intervention ward, which was interesting. So I think it's a good example of, one, we need to use very robust study designs to look at some of these safety interventions, but we also need to question their value in terms of actually improving safety at the end of the day. So in finishing off, what are some of our ongoing challenges and opportunities in this area? Well, I just think it's such a fascinating area to look at how do people do work in different situations, and then trying to link it to what is successful work patterns, safe work patterns in healthcare. How do we design information technology which is going to support effective work? And also, how do we keep on pushing some of these research methods? We don't want to keep on doing the same sort of study. We keep on trying to think about different dimensions to this question that we can investigate. And I think one of the most important lessons is that you have to look for the expected and the unexpected. Thank you very much. I think there has been a big shift in that conversation, because in the early days of EMM, people were, absolutely talking about, we won't need as many pharmacists and things. And I think people are now shifting through a whole series of, evidence and information that's coming to pass that is not the case, and actually their role needs to expand, because now they've got things like decision support rules to manage, and smart pumps to program, and training of clinicians because they're there. And so I think one of the useful things here is being able to quantify some of these shifts, that it's not just a shift in task, but it may be a total shift in their roles and responsibilities. Yes. So I think we're really just scratching the surface of trying to look at some of those issues at the moment. Mustn't ascribe values of good or bad to ups or down in proportions of time, because that's, we don't know what it is. It's actually just trying to describe it. And I think you're right. When we see some of these shifts and things taking more time, the chances are before they didn't have any time to do it properly, and so they were only taking a small amount of time, and now they actually have time to do it properly, and it potentially has better outcomes. But I think it is important to then link that to some outcome indicator to be able to make some judgment. That's a very good question. I think one of the things is that when we did an attitude survey as well about, at baseline, what do nurses think about interruptions, the frequency of them, do they think they're important to their work? And, the vast majority of nurses realise that interruptions are potentially hazardous for them, and they don't like them, and they're viewed very negatively. So in a sense, we've got a group of people that realise there's a problem and the nature of the problem. My sense is that some educational interventions might be as effective and a lot less resource intensive than getting them all to wear a vest. Now the thing is, with a vest, it's nice because it's a tangible thing and it sounds exciting and everything, but once you start trying to work on the practical issues of it, so we had nurses saying, so do I have to put it on if I'm giving a Panadol, and they're whipping them in and out, and then if I'm in it was Adelaide summer, they were sweltering under the plastic, but then if you use cloth ones, they say they're not sterile, etc., etc. So there are all these which often people who are slightly, if I say evangelical about do not interrupt interventions. So I haven't got the solution about what we should do. I think there is actually better education about training people about when it is safe to interrupt and alerting them to the fact that it is actually dangerous. But it's become almost seems to be such an integral part of clinical practice a bit. It's quite hard to shift that it's okay to do these constant interruptions. There are obviously, from Enrico's early work, there are some really practical interventions like people interrupting because they can't find somebody. So if you have whiteboards up, he showed in your early studies in emergency departments, you can put information available to people so that they have the information easily accessible, so there's not a requirement for it. We found with the nurses the drug key, and where they're, constantly people are asking, where's the drug key? Have you got the drug key? So coming up with some practical solutions around those things. And so as part of that trial, we are actually categorising all the reasons why people interrupted to identify whether there are some, really quite straightforward things that you could possibly do just to prevent the need to interrupt. They're all categorised from, wrong dose, wrong rate, particularly IV medications have very high error rates of setting the wrong rate of the things, wrong strength, and we also saw lots of procedural errors, so that not correctly checking a patient's identification prior to administration.
Well, why don't we all give Joe a big thank you.